We're at the Mackinac Policy Conference on behalf of the Michigan Health and Hospital Association and the Common Bridge podcast and Substack page. We're talking today with a very senior healthcare executive, been chief executive in more places than I care to name, Rob Casalou. Rob, great to see you, my friend.
Nice to see you, Rich. Thanks for having me.
How have you been, and how's the conference been?
The conference is, every year is a little different, and this year it's an election year. So, everyone's got their election wings on, and there's a lot of talk about the midterms and a lot of anxiety up here this time around.
Indeed, and healthcare is front and center this year. We're not talking about too many other things, climate and economics and the interest rates and those kinds of things you're not hearing a thing, but boy, are we hearing about healthcare.
Yeah, well, we've been on the menu for the last 2 years with what happened in D.C. and, all the discussion here in the state of Michigan and across the country. So I'm not surprised. And let's face it, healthcare is growing enormously expensive every day, and it's unsustainable the way we're doing it.
Indeed, we have to look at fixing the system. Can't be fixed by the components.
Yeah.
Now, you've been chief executive of health systems in Michigan. You've been health system CEO of multiple systems that you've been responsible for. Mm-hmm. And you've also, in recent years, taken some responsibility for Trinity outside of Michigan.
Correct.
And one perspective we have not had a chance to talk to anybody about today is, how are we doing compared to other states? Are we doing some things better, some things worse? What are you seeing out there?
Well, we're seeing the variety. We're in 25 states. I cover about 9 of those, and, everywhere from California to Idaho. So when you start talking about the politics in the states that we're in, very different. Michigan is clearly a purple state. There's no doubt about it. But when I go to our hospitals in Iowa or California or in Idaho, it's more homogeneous on the politics. And I'm seeing some interesting things. Like, for instance, we talked a lot about denials and that being a big issue with commercial payers, kind of using denials as a strategy to not pay. Mm-hmm. The state of Iowa passed a law recently penalizing commercial insurer for denials.
How does that work?
Well, we're going to see how it works because this bill just passed. But I think the Iowa legislature, which is largely Republican and conservative, has listened to the healthcare community saying, no more. Now, I think also there might be a little guilt in all of this because when H.R. 1 got passed, largely by a Republican, majority in the Congress, it hurt healthcare. It hurt it, and it hurt it in states that they rely on those voters. So I think some of the more what I'll call red states are now looking at what they can do to help hospitals, believe it or not. Michigan right now, we're swirling on issues here that other states are kind of landing the plane on, like 340B, like, things like denials and all that. You don't see a lot of bills getting passed in the Michigan legislature because there's gridlock on those issues.
I see. So denials, would be a fascinating topic, but I guess if you penalize somebody for doing a denial that they ultimately approved, wouldn't that give them more incentive to sustain the denial? I mean, that's why I'm curious how that might work.
Well, I think it's really being more reasonable about it. There's different ways to deny, right? You can just say, I'm not going to pay it and come up with a technical lame reason to deny it, or you can ask for more information. Maybe the medical record's not complete. There's some legitimacy in making sure that claims are legitimately paid. But a lot of insurers have taken a lot of liberty with that. A lot of the big nationals like United and others have done that. And I think that some of the states are saying, enough. Okay, we're not buying it, and we're going to put more restrictions on your ability to do it.
I can't think of 2 states that are more different than Idaho and California. It's
very different. Yeah.
What are you noticing the contrast between those two, and how does it relate to our state here?
Well, one thing and this is actually truth, there's humor in it, but when I was in Boise just a week ago, the population in Idaho is growing. Boise is exploding in growth right now. And I said, where is it coming from? And they say it's political refugees from California and Oregon. And I said, are you guys kidding me? And they go, no, it's actually true that people are choosing where they live based on their beliefs, their values, their politics. And so I've been watching that. Now, in states like Idaho, where they're extremely conservative, where we as a faith-based system come in, gets pretty tricky because they have very high standards about things like end of life care, beginning of life care, and we're challenged as a faith-based in some of those states because they hold us to a certain standard on those, and the bishops and all that are very involved. But politically and policy-wise, everyone's talking about the same thing. So 340B, site neutral, all the things that we talk about are the same topics in all the states, and they're all kind of wrestling with them a different way.
Anybody doing a good job with them?
I can't say that with a straight face. I would say that, Iowa example and denials, yeah, that's a good. Maryland has a very unique reimbursement model. We're in Maryland as well. They have this kind of global budgeting. It's been there for decades, and it's now being looked at as a potential model for reimbursement across the country. They're kind of experimenting in the state of Maryland. A lot of people don't know that. It would be worth watching Maryland for a little bit to see if their new pilot, the way they're going to redo the program, actually could make sense in other states.
Let's turn to the MHA for a little bit. MHA's long storied history. It is the only association of its type that has 100% membership. If you look at the MHA, what kind of job do you want to see them doing, and how are they doing?
Well, I think I'll answer it the same way I think I'll answer for our industry. We're sometimes our own worst enemy. And let me use 340B as an example. We've been fighting pharma on 340B. It's not even a taxpayer issue. We all know that. It's pharma money going to hospitals and to people. We've never put a face on 340B. We've never said, here are the people that actually benefit from this. This isn't about hospitals' bottom lines. It's about who are the people in the communities that benefit from this. And we have done a really lousy job of humanizing some of these programs. We get all caught up in the technical part. MHA, I think, can do a better job, as we all can, explaining the benefit of these programs. And it's not about padding bottom lines. And I just feel like right out, and when you talk about site neutral, everybody's eyes go in the back of their head, right? What does that mean? What is hospital-based pricing and all that? All these archaic things that were put in place at one time for a really good reason. And those reasons maybe still are justified today, but everyone's forgot them. There's no institutional memory. So MHA and the industry leaders, we all have to keep coming forward and having conversations and educating people. And I feel like that's half the battle for us right now.
Indeed. That makes a lot of sense to me. If public service announcements were humanizing, this is the issue, and it's kind of like ask your doctor if this is right for you. Ask your legislature if 340B is good for you. It would help actually ease the job of the public policy part of the MHA's Michigan. And of course, they do a great job as a convener and getting people to talk.
Oh, yeah. And they are a powerful voice because they know they represent us. So when they're talking to a legislator, that legislator knows they're talking for 134 hospitals. They're not talking just as a lobbying organization, because member unity, and I will say this, all the other states I work with, this is by far the strongest hospital association, health association in the country that I've come across. We have some good ones, but MHA stands above them from my experience.
Indeed, and I'll echo that. I had many of them as clients and spent a good amount of time with them, and Michigan is clearly the gold standard.
Yeah, oh, for sure.
As far as that goes.
Yeah.
So good job, Brian Peters.
Yeah,
okay.
No, Brian and the team have done a great job. Yeah.
Yes, they have. Rob, when you think about healthcare policy and what we could do as a state or as a nation, and I'm sure there's probably a long list of policy changes you'd like to see, what if there was one or two things that you said would make a difference to us, what would those be?
Well, one is, Rich, we have things coming at us from every direction right now. So HR 1 took a huge bite out of us, more coming than actually has happened yet. But when that hits next year, we're going to take a devastating loss of revenue on Medicaid. At the same time, they put 340B, site neutral, other kinds of issues on the table. If they all go the wrong way for us, this industry is going to be crippled. I mean, I'm not being hyperbolic. It will be devastating. So one of my hopes is stop. You've done enough. Why don't you just take a breath and see what happens when HR 1 actually goes into effect? Because you may be losing hospitals and people along the way. And if you do 340B and site neutral at the same time, forget it.
I mean, the system could collapse.
It could, and they really got to be careful what they're doing here, and not, and I think for us, one of the things I'm hoping for is kind of a relook. You really want to do something meaningful. Then everyone says our Medicaid system is so complex, and we would never have designed a system like this if we could do it over again. Okay, folks, then do it over again. I mean, they're complaining about the system that we have and how it's been kind of sausage making for years on the Medicaid program, provider tax, all this stuff people don't understand. If you would design it from scratch, then do that. I mean, come on, folks. We're all smart people. If you don't like the system that you have, don't keep trying to cut the one that you have, fix the one that you have.
Indeed.
And I think if we would, 72% of all of our patients in the state of Michigan for Trinity are Medicare and Medicaid. So we are almost a full government payer organization, like every other health system. Commercial insurance is becoming a fraction of our business now. No offense to Blue Cross or anybody else, but it's a Medicare and Medicaid show now. If we don't fix those two programs, this isn't going to work real well. So that would be my hope for a policy.
I would strongly support you on that, because the numbers show that we are pretty much at a government-sponsored health system anyway. Nationally we are.
Yeah, I mean, and it's crazy because we're not a single payer system, although we're kind of looking like one, and yet we have all the administrative costs of a non-government single payer system, because Canada doesn't have insurers and all these. I'm not trying to tout we should be Canada, by the way, but all I'm saying is they don't have layers of costs in their system that we have. So we got to think about that.
Yeah, yet their patients are lined up at the health systems in the United States because they can't get access up there.
We treat a lot of Canadian patients.
Indeed.
Yeah,
some of that spend is capacity that we're buying in the U.S.
Absolutely. Yeah.
We've been talking with Rob Casalou, one of the most senior chief executives in healthcare. So on behalf of the Michigan Health and Hospital Association and the Common Bridge podcast and Substack page, this is your host, Rich Helppie, signing off.